Good evening, everybody, and welcome to the second part on the talk about teaching anatomy, how it has changed over the years. We are extremely happy to have Dr. Balasubramanian again. His last week's talk was riveting, and everybody is looking forward to the part two. Today's topic is digital wins for augmented surgical understanding. Over to you, sir.
Thank you. Nice to be back with your team once again. I will continue from this slide. This is where I stopped last time. Learning is an individual achievement accomplished by an individual learner at an individual pace in response to individual motivation and personal reward. We believe technology is not a means, is a means, but it is not the end. This is where we stopped last time. Now, I will take you through a journey of some of my experiments with technology. I'm sure you will all agree passive learning is as bad as passive smoking or active smoking. It doesn't matter. It's as good, as bad, or as good as smoking. So basically, whether the candidate is going to end up as a surgical in a surgical line or a medical line, as far as the foundational education is concerned, there has to be a participatory learning. All the more if it is a skill based science where he takes up a surgical line, is what I'm trying to say with this slide. Now, you see, there are cadavers, there are students, there is also technology embedded into the teaching program. This is from my dissection hall. You must be wondering what's happening when the cadaver is there, what these students are doing. Don't get me wrong, this picture may be misleading. Actually, what has happened is a certain stage of cadaver dissection has been completed. They have all been now called to attention, and from the server, some kind of a question answer or an MCQ session has been put on, and they are now answering the questions. In about 5 minutes, they will all be back with the cadaver. You can actually see one cadaver there. So basically, what's happening is, as they are dissecting at a particular stage, they will be told that there will be some kind of a supervisory or some kind of a mentoring or a monitoring, some kind of a check whether the progress is as expected. This is what I'm trying to say with this photograph. As I said in a previous lecture, no matter what, the teacher is the primary content provider. There is need for content. Technology is no exception. Unless the teacher is available to give the content or tailor the content or customize the content, there is not going to be much progress in this art.
Sir, you got muted, sir, accidentally.
Now?
Yes, sir.
Okay. Should I repeat some of the previous slides?
No, sir, just this sentence, sir.
Thank you. Thank you.
Yes.
Next. Next point I want to mention is, I mentioned participatory learning. By the word participatory learning, I mean we have to give the student opportunities to take some kind of a role or some kind of a participation in the clinical process, although he is still in the preclinical science. Now that's a tough job. How do you expect to do? That is exactly where this what I would call as interactive computer graphics comes into play. I will show you an example where treat me as a student and I am playing the computer game, and you will see how interesting this knowledge acquisition is. Remember one thing, by using this program, I am not going to teach the student what is blood grouping, what is RH group, what I believe that segment of the instruction has already been given to the student. Now is the time to let the student loose on a clinical case scenario in a virtual safe learning mode. I may not be able to take him to the blood bank and give them one whole day to do one blood test. I gave you the example in the previous lecture. I told there is a road traffic accident and patients are being wheeled into the casualty, and your job is to draw blood. Second, to cross match. Next, pull out the blood from the blood bank, double check whether it crosses matches with the patient's blood, and then give it. Now we are going to play the video game. Are you all with me now?
Yes, sir.
Yeah. Shall we start the game? Yeah. Patients are coming to the casualty. 3 patients are waiting. I'm playing the game, okay? It's a video recording. It's a screen recording, okay? So some instructions are going on. First patient will be wheeled in. Now you see, syringes are there. Corresponding test tubes are there. I bring the syringe, keep it there, draw the blood, put it in the 3 containers, 3 test tubes. And now it is not telling me what is A, what is B. I am supposed to know. And based on the observation, I must find out what is the blood group of this patient. Next, I have to go to the blood bank, pull out the blood, whatever I think is appropriate. See, I put it into the you see, it's good. Now patient needs more blood. Let's see what happens. Equally good. But then let's see when there is a problem, how the system prompts that student to come out of this. See, in other words, I can make mistakes. Again, no problem. Now you saw what happened. Now it gently tells that there is something wrong. It intervenes, gives the correction, and then proceeds. Now that was a simplest and a very entry level demo of a virtual reality scenario where in the confines of a protected environment, the student is able to uh, learn by making mistakes. For the first time in the history of medical education, we are seeing scenarios where making mistake is not a sin, making a mistake is not an embarrassment. That's the way to learn. Only thing is, there is a protective shield during the learning process. Likewise, I will show you a few more. Imagine if I can show this for a simple procedure like this. If I can bring in haptics, I can bring in other modalities, other sensory systems into the thing, and then bring in proper skill based training. You can imagine the level of confidence the student is likely to pick up. In other words, from last session, we started that until recently, we thought cadaver is the only and is the ultimate foundational teaching material on which the entire surgery is going to be based. Slowly, as we realized that it may not really be so, probably we thought so because we had never seen other supplementary technologies which could have added value. As the computer technology advanced, we began to see its potential, and slowly we realized there is a huge armamentarium of technology supplements which can add to the students' understanding, better understanding of the student. Now we'll proceed further. Therefore, gamification of anatomy education is a major step in improvement of the learning. So pedagogy is getting changed to accommodate additional value added methodologies so as to benefit the student. Therefore, medical video games is the future of medical education. Now we'll play another game, slightly skill based, you know, clinical diagnosis and things like that. Now you can play it at leisure. It's a flash game, but I'm going to play it here just one or two slides only to show you how when the dissection class is going on, you see actual dissection hall, I allow this program to be run by my students. And as they dissect, they play with this video game. And for the first time, I believe that it is not necessarily education that is going on. I am bringing in an element of entertainment into the system. Together, the student begins to pick up interest because he is playing in a clinical scenario. Now, let me explain this. I think there is at least one ophthalmologist in this session today because she told me she will join. Madam, have you joined? Okay. Anyway, if there aren't no ophthalmology, anyway, we will think we are all ophthalmologists. Now, when I move the cursor, treat it as the equivalent of you moving your fingertip. So the program is also so designed that along with the movement of the finger, the eye will also move. Then what you do is you paralyze one muscle of your choice, and then you move the cursor, and you can see here on the right side the eyeball has not moved, but on the left side when I raise it, the eyeball has moved. Similarly, I can go to the next step and paralyze one cranial nerve. You see, the moment I paralyze the cranial nerve 3, oculomotor, you saw what happened? There was ptosis. So this is only a demo. I am not showing the actual program. I will give you the link. You can go through. Once the lid is closed, there is no further clinical examination possible. So the program provides you the facility to open the lid. It gives you a digital torch. You can actually shine the torch on the pupil and you can see whether there is myiasis or mydriasis, things like that. This is one, this is the training mode. So it gives case after case and scenario after scenario, or you can paralyze groups of muscles, one muscle this side, one muscle that side. You can have permutation and combinations and create your own clinical scenarios and learn in the process. The same program is also available in evaluation mode where it presents a scenario. It doesn't help you in any way. You have to come to a diagnosis. So this is another simple entry level, absolutely free program available on the internet. You see. Next, time and again, I'm bringing in the point that there has to be some kind of a participation in the learning process. But then that's not all. I have seen that in instead of one single student and the computer, you put a group of students, allow them to chat with each other, talk to each other, make have some fun, and then come back to the subject. And then once the subject details are put up on the screen and the team has to interact, they get so engrossed that they forget time. That is what I'm trying to say. In other words, it's just not the equipment, it's the way you present the content and how you allow the students to talk with the system. See, this is not a photo shoot. The students didn't know that I am clicking the photograph. This is as early as 1998. See the rapt attention of the audience when some animation. This is something to do with embryology. You can see the attention of the audience. Therefore, therefore, we are not here to say dissection is out and the technology is in. No, that is not the point. As already commented in the earlier sessions, we are trying to bring in the concept that no single pedagogical technique is good enough in its entirety. With the advancement of newer communication methodologies, particularly in the IT field, there are uh, ways by which the best of each technology or the pedagogy can be brought in, and therefore it will be more like a plate meal. That means a little of everything, the good of everything will be there, is what I'm trying to say. In other words, we are heading for a new system of education where it gets blended into the learning system. You can see that I am teaching, students are going through the thing on the screen. Later on, what I do is I move out of the scene. You can see the students on their own going through the same thing. This is in my dissection hall. Next, I have made a series of 192 dissections for my students, videos, and I have put it on the YouTube in my channel, absolutely free for my students till date. Now, the point I'm trying to say is these were all a series of evolutionary videos which was improved upon from time to time. Now, the experiment I'm trying to talk to you is students are students. I'm sure we are a close group. We will all agree that when we were students, we were no better. This is what is happening in my department. When I say the 1 week or 15 days early, my timetable is put on the notice board. The students don't read the particular area of dissection and come, no matter how tough you are. Therefore, I had to find a method by which we have to bring them into the system rather than punish them for not cooperating. Therefore, what I did was, because they don't read and come, they're wasting their time getting the basics on the dissection table. What I do is before that day's dissection, I make the students go through the video of that dissection. Only thing is that video will not be very elaborate. It will be to the point. It will be a maximum 10 minutes, 15 minutes, where all the items will be demonstrated. In the earlier days, when I did not have internet, I did not have all this smartphones, etc., I used to put it on a big screen, and the whole group used to view it. Subsequently, as technology evolved, I gave them the link, and they were all seeing it on their own. Ultimately, this is the success story I am talking of. I not only made sure that they see it once before, but now, because it is available in the smartphones, our anatomy department has been given the special permission that they can use the internet on their smartphones during the dissection hall and the histology postings. I had to really fight it out with my dean to get this permission. And now, as the dissection is going on, I'll show you the photographs. They again go back and look through the video and try to get a higher level of understanding. So, to this extent, I can see silent yet very strong supplementation of the teaching learning session is going on through an enabled technology. Therefore, what I'm trying to say is such immersive learning experiences can add value to the student's understanding. Now, this is not my domain, but because I am addressing a group of surgery students, I have put this thing. I think you as surgeons will have more knowledge about all these technologies. Now, you see, the millennial student and how technology is being adopted is what I'm trying to say in this. There are three things I want to mention. Skill acquisition. There is a strong role for teachers to guide the student to pick up the skill. The patient is the best teaching material. But the problem is, this kind of teaching is opportunistic and situational. You tell all the students to learn all about hernia and come, and on that day you don't get a hernia case, you get a varicocele. Well, you have to accept it and manage with what is available. Okay, but there is a supportive role for computers, at least in the early stages, where you can take him first through a virtual scenario and then lead him to the bedside clinics. Therefore, as already told earlier, I'm going to skip this slide. Decision support systems, clinical decision support systems is not only good for, yes, please, is not only good for the practicing teachers, but is also equally good for the medical student to learn. Next, this is what I said. Computer-based video show, I told you. Students are seeing it either on their laptops or on their tabs or on their cell phones before the start of the dissection. Basically, a situation has occurred where we are able to deliver information at the fingertip at a time when the student wants. You will have to extrapolate it to the clinical side and see whether such a facility of material, teaching material, the appropriate content at the appropriate time is available to the medical student at the bedside. Now, I cannot answer the question, but I can say even in my corridor, this is what is happening in the classroom, in the anatomy department. Now, you see, Next, let me tell you how I was able to imbibe technology seamlessly into the system without interfering with the general flow of the classroom. Because I told you these are not to be treated as disruptive technologies. Rather, they should be treated as complementary technologies, provided they serve the point. I'll explain how I present it, how I utilized it, and then you can take your own call. Now, you see, there is only one teacher in this photograph. This is only a part of the histology lab. All the students are there. This, as on the day of this photograph, there are about 30 students in this lab, but there is only one teacher for some reason. Now, the question is, out of 30, when it is a first time histology, at least 10 to 15 students will have some doubt or the other for which the teacher is required to help them see the sites, identify things like that. But then what I have done is, if you see there is a screen there, I have put a running video of that day's histology. What do you mean by video? I have clicked the photographs of the very same slides they are seeing. I have labeled it. I have made it into a PowerPoint show, and every item they are expected to see as per the curriculum is labeled, and it shows in any single slide at any particular time only two or three labels will be there. Then the same slide will repeat, the labels will be different. I loop it up so that every 3 or 4 minutes the same slide will repeat. Suddenly I realized students are not demanding the attention of the teacher as before, because there is an aid, it is not making noise, it is quietly playing the video, scene after scene, slide after slide, quietly without audio. Everything is labeled. The dependency on the teacher comes down dramatically. I got this inspiration when I was going for some examination duty somewhere, and in the railway station, I noticed that although there are so many screens and so many arrivals and departures, not everyone is looking at the TV screen. Only those who want to know the arrival of which train at which train are looking at it. And they wait till the arrival or the departure screen comes and find out, and then they go to the platform, etc. etc. Same story here. I said, if this can work so seamlessly in a railway station, why not it work in my anatomy department? Even today, this is going on. We are using it successfully. Histology, every single histology practicals, we have this running. Earlier days, when we did not have those big screens and all, even with the ordinary small monitors, we were able to manage the same thing. Subsequently, you see, you can see there are two projectors going on, because notice that the people at this end of the thing were not able to see the thing clearly. So I arranged two. Even today, as I talk, two projectors are there and they are running the slideshow. Finally, you see, in addition to it, the same material is available in an instructional video with audio narration on my YouTube channel. You can see the students going through that even more, because what is put on the screen is not audio narration, whereas the YouTube gives you audio narration that is also being used. Therefore, I have brought in technology in a very, very seamless entry, quiet entry, but it is making a lot of impact on the students' confidence levels at the end of the session. Of course, infrastructure at a higher level than this, institutional support is definitely required, and I'm sure with the institutional cooperation we can do much more. But then there is a limit to which what you can do solo. Next, even in the lecture halls, we have tried using the computers. And the next question was, some teachers may or may not like computers being there and students playing with the computer when you are giving the lecture. The point is not that. I'm not saying either you listen to my lecture or you play with your computers. No. The students are encouraged to use the computer at strategic points in the during the talk, where I take a pause, I give them the web link. They will all go to the web link and they will study it for about 10 minutes and then say, now back to the lecture. Now I will tell them, now from that point onwards, we will discuss further. So if I can if I can bring in a small element of computer interaction into the lecturing system itself, then we are able to see some benefits. Next, same thing is happening. My student is drawing the thing, and there is already he is looking at the cell phone. Obviously, it is from my histology video that is there on YouTube, and he is going through, and then he is drawing or whatever it is. The learning process is being supplemented. But when I have to extrapolate it and scale it up for the clinical side, I believe that there are higher domains of interactive learning, which is all the more appropriate for the clinical side, even more appropriate for the surgical side. There are a huge armamentarium of interventional tools, equipments in terms of hardware, software, etc., which can be brought into the system, and the students can be taken on a panoramic tour with appropriate supervision, and the students can learn. This is a photograph clicked by me. That is why I have not seen in this video, but I was trained on this technique in Singapore. I'll tell you what is this. This is that famous software and hardware called Harvey, where the teacher is actually using his stethoscope, digital stethoscope. He is showing some murmurs, and you can see on the top, those are the participants or the so-called students. All of them have one stethoscope. The point is, because of Bluetooth technology, what exactly the teacher hears, the same thing is being transmitted to all the stethoscopes. So there is no confusion. I hear something, then the student hears something. So there is across the student population, there is equity in terms of the same material being heard, so they can understand better. Then there are some switches here. You can see the teacher will press the appropriate switch, and he can create the lesion. Let us say mitral stenosis, some kind of a murmur. Next, he will remove it and put aortic stenosis, some other murmur. So he can create clinical scenarios in real time on a virtual patient, and then ask the students, can you see this, can you see this? So in about an hour, he can take them through a panoramic journey of say about 200 different auscultations. So this is called Harvey. The same program is also programmed or set for evaluation purposes, where just before the exam, the teacher will program such and such a lesion, and the students are expected to identify the lesion. I am not sure whether our MBBS students are competent enough to have such advanced level, but the level of screening and the level of fidelity is left to you, the clinician. Similarly, if you talk further, very challenging learning environments are there, and entire ecosystems of teaching learning scenarios are now available. Depending upon the enthusiasm of the teacher and the cooperation of the management and the compulsions of budget, you can try to implement as much as possible in your establishment. The next one is augmented reality, where I'm sure all of you surgeons are more seen much more practical issues of augmented reality. But then I am getting into the field very in the last 1 year, and I have done some experiments. So what happens in augmented reality is it gives you that extra dose of interaction to an actual clinical scenario. I'm sure you have seen this in Google Maps, where if you go in search of a thing in a particular direction, let's say Bangalore to Chennai, as you are going, it will even tell you which restaurant is available along the road, next 1 kilometer, what is available, etc. etc. Same story here also. It gives you that extra dose of value, using which you can navigate your path and navigate your skills with a better clarity. That's augmented reality. Now, finally, we come to dissection hasn't changed, but our perception has changed. Now, I told you that I will be presenting a small program on the embryology. Just watch this video. This was done by me, and I'm sure all of you surgeons, general surgeons, will agree that teaching the development of the gut is one of the most challenging topics, not only for the student to understand, but also equally challenging for the teacher to teach. So this was somewhere in 1990. 6 or so, I tried out this program. Of course, I had a student who helped me develop the program. Programming is not mine, but the design is mine. You see, I have removed the gut loop. I will show in this program foregut, midgut, and hindgut. Then I interact with the system. You see, if you watch carefully, you will see some interaction and some kind of animated step-by-step dissection. I mean, progress of the development of the gut tube. You will see the liver reaching its final position, the stomach rotating and reaching its final position. Just watch carefully. Now, this is for orientation. In every single item at that stage of embryological development, I am labeling. He clicks a button, the student, and goes to the next screen. And then the animation takes over. Now, the speed is entirely under the control of the student. The slow learner can go slow, the fast learner can go fast. You see, now you can see the animation going on. See, some stage of the rotation of the gut is taking place. Now I'll stop this video. I just made a point, that's all. Therefore, uh, I have to make a strong case that it's not the cadaver, but there are certain domains beyond the cadaver where technology can help. One of the strongest territories where computer animations can be a compelling need or a very demanding necessity is the domain of embryology animations of various developmental stages. In 2007, later on, 10 years later, I had the opportunity to work as the academic director of a medical e-learning company in Hyderabad. And that was a God-given opportunity for me to develop the entire animation for uh, embryology, all the systems, general embryology as well as systemic embryology. So I have the privilege of having done this for my students. Um, I do not have sufficient, uh, I would say, competence to take you through this journey. But I suppose Dr. Rama is there in the audience. She is our clinical geneticist. She has been using this software very extensively, and I hope she can lead us further on this. Basically, this is a clinical decision support system for identifying difficult cases where certain rare syndromes are there. We use this database, we feed in the clinical criteria, and with the help of computer graphics and the internet literature, we are able to narrow down the diagnosis, and the amount of time saved is tremendous. We are not at the present at this point of time living it for our students, but we are using it as a clinical or in our clinical armamentarium in our genetics division. I hope Dr. Rama is there, and later on she can give us more information on this. Now, this is what I was telling you about, namely the. It's kind of a digital reality. So what we now before the demo starts, this is the experimental work which I am sharing on virtual reality. You can see how immersive you can be. We have just heard of. I'll just give you an example before I play the video. See, even in a cadaver, when I do a dissection, I reach the mediastinum of the thorax. I see the dissection, I see the trachea, I see it dividing into the bronchial, tracheobronchial tree at the hilum. That's all. After that, I don't know what's going on. But if I can have an avatar of the cadaver, that is by the word avatar, I mean technology avatar of the cadaver, where I can put myself at any point on the virtual cadaver, and I can virtually navigate my way into the interior of the lung, which we normally cannot do in an actual dissection. So I can move in deeper and deeper into the bronchioles, into the various bronchopulmonary segments. I can come back and go to another segment. I can do a lobectomy. I can cut a vein. I can cut an artery. So can I actually be in the midst of my dissection rather than just viewing the dissection or just cutting the structures and seeing the dissection? That means, can I have an extension of my actual skill based dissection on the cadaver? Concurrently, can I have a digital extension where I can manipulate it much more than what the cadaver itself is going to allow? Suppose I'm dissecting the heart, actual heart dissection in the cadaver. I can go into the right atrium, sit there in a closed chamber. See, and I can move it. I can bring in hemodynamics into the system. I can make the valves close, open, close, open. I can understand the physiological basis of all the sounds that are produced. I can create turbulence. I can put a venous line into the system. I can add whatever ion I want, sodium, potassium, calcium, in real time. I can calibrate the dose. I can adjust the dose. I can increase the dose, decrease the dose, and I can see the heart reacting in real time, all side by side with the cadaver. Now that's virtual reality and augmented reality for you. So having understood the concept, doesn't matter which aspect of this video we see. Now what I'm trying to say is, don't wait for somebody to do it for you and then start using it. You have to pay a price and you have to wait. And after all that, you may not get exactly what you want. Instead, you be the change. You do the change. You bring the technology in, and then you see the difference. In other words, let's not uh, end up in a blame game, but let's all plunge ourselves into the system and try to uh, you know bring in a more meaningful understanding for the student who is making his career into the surgical specialties. Started at 8 as promised. The time allotted is 40 minutes. It is 8:40 now. I will stop this demonstration and discussion at this point of time, but I'm sure, like last time, we will have a huge battery of question answers to follow. Thank you.
Sir, I think you can continue that and finish your presentation. We're still enjoying it.
Yeah, but then I have brought the talk to a particular point where I need to pause. That's what I'm saying to say.
Okay.
Ilango, with your permission, I'll invite Dr. R.S. Shastri, who's a chief surgeon KIMS and is my teacher and boss in Nizam Institute. And to say the least, I think he's married to computers and information technology much before any medical man in the country, because I had worked with him about 22 years ago. And then he was very, very proficient into computers and making software and so on. Dr. Shastri.
Am I audible?
Yes, sir. Loud and clear, sir.
Thanks, Radhakrishna. But unfortunately, my marriage with the computers had sort of stopped some time back. It stopped with the database management systems, the decision support systems, clinical decision support systems. Yes, we toyed with some idea with some time back, but then their workflows, you are busy in other areas, and then lack of interest in the users. This kind of thing has really put me off. But then I must compliment Dr. Balasubramanian for it's been a real wonderful exposition. I've learned so much. We only heard of virtual reality and augmented reality and sort of saw some of the instances on the web. But in real time, in the basic sciences teaching programs, complementing it with the regular teaching, I think it's a remarkable achievement. I must compliment him again. I'm only aware of the simulated learning in some of the skill labs, also fascinated by it. But then to integrate it into the regular learning in an undergraduate system, I think it's wonderful. And my only concern at times is, how do we integrate these? Does it lead to a disrupted kind of workflow? There is a criticism that some of these, sometimes lead to an increased cognitive effort on the part of the learner. He has to learn both ways, concentrate on this and then integrate it with his regular learning. I do not know how we achieve that kind of integration. Clinical decision systems are, I do not know. I'm not sure whether they are perfect systems. But I think for undergraduate training in basic sciences, I think these are really wonderful tools to enrich the curriculum.
So if I may just interrupt, one of the things I really struggled with in my MBBS course was anatomy, and I wish that this kind of stuff was available. Probably I would have done a lot better. Or maybe I should go back now to learn it once again. So definitely, I think if any budding surgeons are there, I think they should go and spend some time with Dr. Balasubramanian to relearn their anatomy in a more exciting way. But I can vouch for what Dr. Balasubramanian said, because now if we are into ultrasound guided nerve blocks. So having, like you said, having a background video running or just seeing the video before doing makes a lot of difference. Even when you're doing it often, that before I do the block, even if I've done it 50 times before, I still, open the video, look at it, and then go and do it. Just makes me feel more confident, and I feel like I do a better job. So I completely agree with you about having the background thing running makes a big difference.
Balasubramanian can respond to Dr. Shastri's point.
You want me to respond?
Yeah.
Yeah. Thank you, sir, for those extra points that you mentioned. The issue is, how can we integrate this kind of material with the clinical sciences? Well, I am ready to sit with you and discuss how to take it up. There are a lot of issues, there are a lot of challenges we need to. As of now, all that I can say is, I am ready with the material, whatever material I showed you. We can sit together and we'll have to implementation as an extension of this into the clinical scenario is the big challenge. First, we need the material that is now with me. We need to talk it over. Let me know. We'll see how we can add it into the regular teaching session in your clinical sciences.
Dr. Shastri, I did some work on these things, but I think the starting point I wanted to say is student engagement is really difficult to do. One of the things I learned from Patasar about 12 years ago was the way he conducts his quiz competitions in any program. Earlier, I think before Kahoot was introduced, he used to bring a box of chocolates. I still remember the big silk chocolate. That was an engagement, okay? So the second one now he does is, he started using Kahoot. I have used this on multiple scenarios to engage for appropriate clinical decision making. So when COVID came in, it was very difficult to get people interested. So what we did at that point was I prepared a small Kahoot quiz. I would run the teaching session, and I would hand over my mobile phone because the nurses are not allowed to carry mobile phones in your hospital. And they would use my mobile phone and play with it. So I found a lot of engagement in that, and that was interesting. But I tell you, I took it out because Patasar used to conduct this Kahoot-based quiz competitions in IASG or in ISG or several of the forums in Chennai. The second thing I learned during the COVID time was the simulator for COVID training in NEJM, which is exactly like this. The difference between Balasar's work, which I see, is that his facts are quite well established. His science is pretty well established. So all that he has to do is to do the technology. With us being clinicians, we have to write the facts properly, and we have to write the right sequence. Both of them are very, very difficult. So being a GI surgeon, it was very easy for me to do things in surgery. What I did in these last 3-4 months is to study obstetrics, which I hated during my MBBS days. So that time I had to take down all the facts, break down, list it, sequence it properly so that I could teach students. And the only way I could engage them was that there must be a profit on their side. The only carrot that I could actually find out before, like how we were talking just before the start of the meeting, was the entrance examination. It is a very engaging talk, sir. You talked on education, providing entertainment, engagement, and integration. And I feel that clinical decision making is still evolving. And if we get the facts right and the sequence right, we may be able to engage the students and provide better dissemination of knowledge. Is Professor Amit Ghosh here?
Yeah.
I think before Amit comes in, Dr. Balasubramanian wants to show a video.
Yeah,
Sir?
sure.
Yeah. I just want to touch upon an important domain which can help in some way overcome the problem. You see, I will show you this video. The purpose of showing the video is it's just not telling, I created a video, I did an animation. I want you to concentrate on this video and see how much of focus, how much of depth, what level of fidelity, what level of fine granularity you need, even to make this hardly, 76 seconds video. This, okay. The reason why I am telling is, no matter what equipment you have to put your heart and soul to get the content the way you want it for the students to be understood. So this is the background for which I am showing the video. The video itself was not may not have been possible but for the help provided by the pharma industry at that point of time, because this is done using Maya. It is very expensive at that. This is done by me in 2006 while I was in Hyderabad. You can see the level of um, detail to which the student can be exposed, and where the reality and the virtuality merges, and there is no clear border where one ends and the other begins. Now the program itself is like this. The patient is taking a tablet. It goes into the stomach, and remember, it was done for the pharma industry with the condition that a copy of it will be used by me without any objection for whatever teaching requirements for my students. So this drug gets destroyed in the stomach. Then the same drug is coated with an enteric coated material, and how it goes into the stomach, how the molecules are not destroyed by the acidity of the stomach, and then you will see how the thing goes beyond the pylorus, and the beauty of the villus architecture will now present to you. I don't want to talk, I want you to see, and then you tell me what you felt about it. So now the yellow tablet, yellow thing is not entry coated. You will immediately after this you will see the red color entry coated version of the same animation. See the level of detail. Destroyed by the acidity of the stomach. Now this is the entry coated version. Again back into the stomach. No effect. Now you see the miracle of life will unfold itself. Here it is broken down by the intestinal enzymes. Then it goes molecular till the drug enters the blood vessel. Here ends the animation. Yeah. Now you tell me.
That's very nice, sir.
I'll show you one more.
And while you're getting it ready, can we invite Professor Ghosh?
Yeah, this is ready. I'll finish this.
Okay.
Then you see, this is a very good example. This is a very appropriate model for my students to teach. While I was working as the academic director in Hyderabad, they told me, can you do some experimental work so that we can use it for future? I said, yes, I will work on video games. And this is one of the examples. This program was done in Flash. This model that I'm showing you is not a structural model, although it looks like some structure. This is basically a mathematical model. What do I mean by a mathematical model? The model is depicted based on certain algorithms. Now, the element of virtuality and reality in this is, this heart is both real and virtual because this is how it is. And you will never see in a cadaver a beating heart of this quality. Second, in a living individual with this kind of a coronal section heart, you will never see the heart beating. So neither in the dead body nor in the living body you can get at this. So basically what I'm trying to say is, we have to create intervening scenarios, interface situations where the best of both is brought into the system, and using that as a example, you teach the student the whatever hemodynamics, etc. See, for example, I don't have it in the demo, but what I did further in this is, I created a slide bar. I can increase or decrease the size of the aortic valve orifice. I can increase or decrease the size of the mitral valve, and the program will respond in real time with whatever hemodynamic problems that will be there. Likewise, I can bring in a venous line into the system. I can add a drug, I can calibrate the drug because I called the pharmacology person into the thing. I called a cardiologist into the discussion, and together we brought in. So we are able to do what is known as what if analysis. That means you can challenge the heart in a virtual atmosphere, and it reacts and it tells you this is what is going on. So this is one of my earliest attempts in 2006 to bring in an element of participatory learning. Thank you. Yeah. Yes, sir. Over to you.
That's amazing. Professor Ghosh, you have some words for us?
No, it's truly fascinating. And this is why I come to listen to these talks. Dr.
Maybe you need to
Balasubramanian.
adjust your camera. We can see only half your face. Yeah, that's fine.
Can you see?
Yeah.
Yeah, I can't see myself because of the present screen. I don't know where I am.
Okay. You're in the right position now.
Yeah. Thank you. No, this is a great talk because I'm a lifelong learner, and that's what brings me to listen and enjoy and continuously learn from what Dr. Balasubramanian is presenting. what we have done in the past is taken the best students from the country, selected from a very tough entrance exam program, and then we have put them in a traditional curriculum. And what Dr. Balasubramanian is showing is that students have different ways of learning, and the speed of learning has increased. And the retention of knowledge is very poor if it's only read the way Vidya and I learned, just read the book and do a dissection. When you have something which you can take it with you wherever you go and keep doing those eye movements and all those things, your retention is much harder, much harder, much stronger, I would say, not harder. Finally, if it comes to the fact that why anatomy and physiology is important, is it is the core and basis of everything that we do. So as an internist, I also have to have an augmented reality or virtual reality as to why is this stomach pain happening? Even though I'm not a surgeon, most of the cases I have to diagnose, which correlating with the clinical signs and CT scans and patients' complaints and response to medications. I completely agree with what Dr. Ilango said, that these kind of knowledge is very important for knowledge that we already know. So this is a basic grounded knowledge which everybody has to know, on basis of which you are practicing clinical medicine, which is what I call is a dancing landscape. What do I mean by a dancing landscape? Is all this anatomy and all these things are going on, but on top of it, things are changing continuously, which we are not able to predict. Until now, no model has been able to predict those kind of things. That's why in COVID, we realized very strongly. One of my talk is on uncertainty in medicine. And I've given several talks in which we covered this topic about dancing landscapes. Having said that, I think the field of medicine has changed completely with these kind of simulations, clinical decision makings, but that has not automatically translated to doctors who are there for continuous performance for a long time career. For some reason, doctors are more burnt out with everything that we have thrown, yet one more thing to throw in the curriculum, and yet one more additional thing to be done from the patient standpoint. I am finding their length of stay in medicine shorter and shorter. But the goodness of heart is these kind of technology which has come up has made them branch into different things. So we have surgeons who have given up surgery and doing this augmented stuff. They're working with pharma and other companies, IT companies, to create these kind of models, and yet staying on the speaking pattern and other things where it looks very exciting. So we still need doctors on the ground who will understand that and be able to practice with empathy and compassion the whole duration of time doing this, and use this as an aid and tool, and this does not become their whole life. So that transition probably will happen. It's not happened yet. But if having said that, Dr. Balasubramanian is clearly a pioneer. He's clearly thinking way beyond. But I must bring to attention a knowledge which in the 1960s, Harvard, it's called teaching machine. If you can look at Dr. Skinner, B.F. Skinner, he's worked on teaching machine and programmed book where every student was given a school from the middle age. In middle school, they were given these kind of things, learning points, and they could click on some A, B, C, D. This is 1960s I'm talking about. I don't know what happened to that phenomenon of teaching in US fell apart. It's coming back again, where they can learn at their own pace. Instead of some are active learners, some are slow learners. But clearly this technique which Dr. Balasubramanian has put, it's a more of democratizing the knowledge. We used to have brilliant students in our anatomy who would memorize and battle off all these nerves, and others who are brilliant surgeons now who probably didn't do as well at that time because their method of learning was different. And this technology would have helped, but that's part of the point. So I think we're going to see more of this. This is a movement in the right direction, and everybody who wants to keep their children from playing video games should actually encourage them to play video games just for these kind of things, that these are coming in education. Where are you going to take this next from clinical decision support, which we have now in our electronic medical record system, to just-in-time patient care? All of these technologies are being utilized in bits and pieces based on the patient's receptibility of understanding um, this information. Some get scared, and yet some understand. So when I'm sitting with a patient here in the Mayo Clinic, I do have all these technologies available to me, and I have to quickly assess from the psychology of seeing the patient what kind of knowledge can I give. But none of this would have been available if I had not paid attention to my teachers in anatomy. So anatomy is the mother of science. It really frames our mind in the right way. If you have to shortcut it and say, "Oh, don't go to the body at all," I don't think that connection, um, taking out the connection, will really hurt us. We need to see that human being who was a human being at one time now is a muscle, and of course, you have other ways of learning. That really forms the basis of how things are, how things develop over the course of time. But thank you again for bringing this excellent up.
Thank you, sir. Thank you.
Thank you, sir.
Can I have the permission of the chairperson to give another demo?
Yeah, sure, sir. Go
Yeah.
ahead.
Before I give the demo, let me explain. It's just not doing some animation and showing it. You say, I have brought in technology. It will not work. I will show you this example. This is a neuroanatomy animation where I am trying to demonstrate the complete course of the pyramidal tract in about 30 to 32 seconds. But the point I need to bring to this audience is it is not the animation. It is very easy to do the animation. But the point is you have to tailor it to the cognitive load of the student at that point of time in his understanding. If you miss that and if you overshoot, he will take a dislike to the subject. You will have to introduce the material in very perfectly calibrated steps into the system. Otherwise, it is going to be an utter failure. Therefore, what I'm trying to say is bring in technology, bring in any pedagogy you want, but make sure it is at the appropriate time, at an appropriate level of understanding to the student. Now, you see the video. This was again done by me in 2008. See the video. If by mistake, out of over enthusiasm, I show this video of the pyramidal tract before the lecture, the student will run away from the class. Instead, I draw with the chalk. I show the details step by step, little by little. He draws with me on his paper or on his book with a pencil, labeling everything. He participates and slowly raise him, give him small installments of knowledge. And at the end of 1 hour, therefore, let us summarize and see the complete working of the pyramidal tract. And then if I show this, then it makes sense. You see, that is why every time I am talking, I use the word meaningful understanding. If it is not shown at the right time, it can be disastrous. Now watch this video. We will now see one of the descending tracts, the corticospinal tract. You can see the motor cortex there being highlighted. The model now turns, and now the fiber will now descend towards the brain stem. That's one. You can see labeled here the various structures along the path of the descending fiber. Now the model turns and the camera will focus along the root of the fiber. Now you are in the internal capsule. Below is the form. Above the cherry red color is the now the model will turn and you will see the same track from front. Now that's the track in the middle, 2/3 of the crus cerebri. Then in the ventral part of the pons, lower down, the pyramid You see, it is a complex topic. You will have to be careful when you present it to the you can break his interest and his commitment to the understanding of the subject, or it's a double-edged sword. Used at an appropriate time, you can make him a neurosurgeon in the long run. The choice is yours. To conclude my short discussion, all that I'm trying to say is everything is available, everything is affordable, or we can make it affordable. All that I'm trying to say is we are the change. Don't wait for somebody else to change. We are the change. Thank you.
Thank you, sir.
Dr.
Thank you, sir.
Ilango, Dr. Ramesh has joined us.
Yeah, welcome, Ramesh, sir. Welcome. Can we invite Dr. Balamurgan for his comments? Dr. Balamurgan, are you there? Ramesh, sir, thank you for joining us.
I'll have only one question to Dr. Ramesh because since he's just
Dr.
joined.
Balamurgan?
Yeah, I think Balamurgan is there. The audio, I can see Balamurgan.
He's not there.
Yeah, no, I don't think so.
Prathapan is also not there. Yeah, I can see Prathapan actually.
Prathapan, your comments on Dr. Balasubramanian lecture and their relevance in surgical training these days.
He's not there. Okay.
Meanwhile, I'll have one question to Dr. Ramesh, which Amit Ghosh is talking about. That I have read somewhere that people who are good with video gaming are good with laparoscopic surgery. Is it true?
Yes, actually, that is very true. But I have been using video games to train people in laparoscopic surgery. But we have to be very careful. Certain video games are not very accurate. They are very inappropriate. You can see some effect happening on the screen. But then it does not translate to your accuracy of whatever you are performing. So we have to select the correct video games. And if we do that, then we can train people. For example, the first time I tried to teach people how to handle a telescope, we have to have a paradoxical movement. So the paradoxical movement, what I made them do is there is a very common game called Speed. The Speed is a video game which we were having a joystick. And with the joystick, you go play a car game and it goes on the road. So I inverted the joystick. And when you invert the joystick, you have to move it in a paradoxical movement. So when the car has to go on the left side, you have to move it on the right side and vice versa. And that was an excellent way of teaching people how to hold a telescope and handle a telescope. There is one Dr. Rosser in US who has done extensive study on video games. And he has, in fact, made a mention of which are the good video games which can be selected. And when people practice those video games, they can, it will be a part of their training in laparoscopic surgery. So now, right now, I'm trying to see some of the new games that have come and trying to make the same, our telephone camera, because everybody has a smartphone today. And we also have this stick which can be used to take selfies. So using the stick and the camera on an iPod, we can actually, I'm trying to see if we can make a gadget which everybody can use at home to practice how to handle a telescope. So some small things like this can really help us. And definitely, one more thing I want to add here is I'm really scared of the next generation, because when 20 years ago, I thought I'm a great surgeon, but then I know our next generation are so good in video games, they will be far superior than us in laparoscopic surgery. Definitely their skills will be better.
Dr. Shastri will agree with that. You're muted, sir.
I'm not too sure whether you can really parallel the video games to laparoscopic surgery. Instead, you have a simulated environment of operative procedure itself. I think that would be much better than training them in video games, which are totally different. Well, these things have to be tested and in a sort of controlled atmosphere and then decide. But to assume that you are good at video games, so you have to be good at laparoscopy, I think is too far-fetched.
Sir, I just want to add a few comments here. See, basically it is hand-eye coordination. So in laparoscopic surgery, the difference between open surgery and laparoscopy is you're seeing somewhere else and then trying to operate, looking at some other screen. So in a video game, you're doing exactly the same. But earlier we had the interface that you use is very important. See, today the joystick that the game console that people use is that multiple buttons, and with both the hands turning it in different ways. That particular console will not really teach them. We have to make something like a laparoscopic instrument, have those sensors of the game console on the laparoscopic instruments and make them practice the game. Then it makes sense. They can really, but to some extent, hand-eye coordination they will get by doing this. But then if you want them to be improving their skills, then we have to design a new joystick or a game console.
But my point is, if I can add, my point is, if you can have a simulated operative environment itself, why go for a video game? You can have various scenarios in an operative environment, a simulated operative environment itself, where you can make the learner practice, or you can practice, and with outcome analysis, it's so possible, so much possible. So I think, training them in video games and then switching over to this would be a roundabout manner. I wonder whether it would add to the learning process. Instead, you create better simulated systems of the operative environment itself. Laparoscopic cholecystectomy with its various scenarios, and let them practice. They'll get a real life experience rather than a competitive experience of a video game.
Sir, again, I want to argue out here, because see, the cost involved in creating a virtual reality game, because I've been doing VR simulations and I've been involved in it for the last 20 years. It's huge, humongous cost. Today, if you want to buy a medical simulator of a lab colleague, you have to shell out at least 1.5 crores. If you want to buy a game console, you will be buying it for 15,000 or 25,000 rupees. So the difference is huge. So when somebody is making something for consumers, they will be planning to sell 5 million copies. When they make it for a doctor, and that to a highly specialized surgeon, they will not be able to sell 500 of them. So there is a difference between the cost that goes to create a surgical lab collie with a lot of difficulties and specialized situations is much more than creating a game. Secondly, I've looked at flight simulators. People who have developed flight simulators, I've taken them to develop lab collie simulator, but they say our lab collie simulator is very complex when compared to a flight simulator. The amount of accuracy needed is so much more. So I think because of this cost, if we can have something that is available for a regular consumer, and we can reproduce that, or we can take it as an application for our teaching, that will be good. Means I'm not trying to say that we have the ultimate design and the ultimate object with us, but at least somebody can have an introduction into laparoscopic surgery by having these things. Later on, they have to develop, and as you said, probably the amount of time they have to spend in a laparoscopic cholecystectomy simulator will be far less. So you are optimizing the usage of simulators, expensive simulators, by using these cheaper simulators to teach basic tasks.
I had a question to
Yes.
ask. It's very
Yeah, Amit,
interesting
yeah.
when I hear this. This is very important discussion and an applied discussion. From a physician standpoint, our work is mainly cognitive. We have procedures, but not like what you do. And we can, a physician can just go up and rise up and learn new things and still have a job. Same thing with the pathologists. They learn new staining techniques and can stay with a job. How is the job security for a general surgeon? I mean, the technology is changing from whatever you're saying. You teach somebody open chole, now it's lap chole, and then it might be something else. So if you were to train a new surgery resident, and I were to join, and I have competition from like the radiologists, especially the interventional radiologists who have taken over so many procedures, what kind of messages do you have to give, or what kind of a mindset of learning and advancement, lifelong learning, teaching, to get these new skills based on technology and whatever the environment is going to throw at a new surgeon? So you have several leaders here. Uh, I feel that your challenges are much more real, um, and actually very evolving compared to the challenges that I face as a physician.
That's Shastri, sir. I think you should start the discussion. That's a big question. That's a big ask.
I know it's difficult to answer in an evolving situation, evolving procedures and evolving teaching methods. It's a little difficult to answer, but then it has to be a mixture of the traditional learning as combined with what Dr. Balasubramanian was showing, the animated pictures and then simulation, maybe in a stepwise manner, and you will have to develop a curriculum integrating all these three methods of the traditional learning, which is just observing your mentor and doing whatever your mentor has been doing. There is something positive in that. After all, mentor has over years has perfected his technique, and hero worship may have some role. I'm not saying that is not all, definitely, but then the other techniques which Dr. Balasubramanian has shown, they're really wonderful if you go through them before you do a live procedure. These things have a lot of challenges in terms of acceptance by the traditional mentors themselves, the students themselves, and then the clash of the cognitive learning techniques itself. There is a bit of a clash there. So how you overcome these would be really challenging problems for the next few decades.
Ramesh, sir, your comments on this?
Yeah.
How do we learn new surgeries?
It's really challenging. Shastri Garu mentioned very aptly what is going on. I think for surgeons, we are, I mean, the fire in your belly makes you get into difficult situations. When I started lap chole, when I started doing laparoscopy, my teacher, he retired when I was in his unit in second MBBS, and then where my father had a nursing home, and he started coming there and practicing. He was 70 years old. He was the chief surgeon of Karnataka when he retired. And he started sitting in my operation theater. He learned laparoscopic surgery at the age of 70, and he expired at 80, and he was performing laparoscopy till the last day. I mean, I think this type of commitment and the hunger in people to get into the best of and the latest things can make them do. Not everybody can, but then I think it's a lot of self-effort and motivation. That's what I would like to say.
If I can respond to Amit Ghosh here before Dr. Shastri comes in. See, Amit, actually, frankly speaking, at this juncture, the very few surgeons in our country are equally good at open surgery, laparoscopy, robotic surgery. I know it's possible because when we moved on to laparoscopy surgery, we achieved something. And then when we tried moving into robotic surgery, well, then, the whole thing is changed, the whole technology, the whole approach has changed. Yeah, I do not know if anybody can master all the three. Actually, they'll move from one to the other. Just
Yeah, I must confess, my residents do much better laparoscopic surgery than I do. Although I've been doing for now maybe 25 years, ever since the laparoscopy started, and we were the first ones to acquire laparoscopic equipment at NIMS in Hyderabad. But then, yeah, I definitely feel much more comfortable with open surgery than laparoscopic surgery. The orientation is different. Although you want to be abreast of the developments, you want to be, you don't want to be lagging behind. So that there is a push for you to get into the new things, just as the other areas of learning techniques, which Dr. Balasubramanian was saying. I know the traditionalists will have some resistance, will show some resistance, but I also feel that to become an absolute master in open surgery, laparoscopy, and robotic is asking for too much. I think you should realize what you're good at. Definitely, laparoscopy and robotic surgery requires more orientation problems. Whereas an open surgery is broad, wide. You don't really require that kind of orientation. I find myself, say, as I drive, unless my wife is by the side, I always turn to the wrong side. If you have to turn to the right, invariably, it's become so much now that if I have to turn to the right, I turn to the left now and I'm right. That kind of spatial orientation is not common in all. It's a gift for some people. So such people should practice the laparoscopy and the robotic more than the open surgery, whereas other people should know their limitations and practice what they are good at. Open surgery is still in vogue. It still has its place.
Dr. Ghosh, I think you gave me a new question to address in Let's Learn Surgery. I think the ability to learn new things, I think, is something we all battle with. And I think youngsters do this battle much more often. There is some advantage in having a mentor who has gone through that pathway, but it's all the more difficult when it comes to learning completely new things. I think we will look into this.
Ilango, you don't conclude. I want to ask Balasubramanian a question.
Yeah.
Sir, you are an anatomist at heart, and most of your work is in relation to teaching anatomy. My interest will be, what can you do to teach general surgeons, to teach neurosurgeons, to teach pediatric surgeons? And since you are into the technology and you're in anatomy, I think that initiative should come from you, where you should have separate modules that every general surgical trainee should be exposed to, this sort of anatomy learning, at least for a few months before they get on with the bandwagon.
Very important question, because from discussing the situation, you have moved the discussion to finding the solution. So I should compliment you for having raised this question, and I have an answer for that.
Can I have the microphone closer to you, sir?
Yeah, I have an answer for that. Now that we know what technology can offer to us, we have what I'm trying to say is we need to move this whatever is available at the level of curriculum mapping. We are all doing little here and there, but it hasn't moved to the university level where unless there is a compulsion that at this stage this part of the thing should be done as a compulsion. See, for example, simulation practice for about say 20 hours, 40 hours is compulsory in the curriculum. Once that comes, then I am ready to offer you my services. Because see, at the end of the day, the medical student is crushed for time. Okay, here is an unfortunate situation. From 2 years, we have brought down anatomy to 1 year. Some are happy, some are not happy. But then remember, in the overall explosion of knowledge, we still are battling it out what is to be taught and what is not to be taught. Therefore, answering your question very specifically, sir, our Medical Council of India very clearly says that at the end of the MBBS course, the medical student will now become a barefoot doctor. Keeping that in mind, the amount of anatomy knowledge that we are currently giving is just enough. Unfortunately, because of the time constraints and so other issues which I just mentioned, this 1 year is just not adequate foundation for a student who is planning to take a surgical career. Therefore, the answer is back to basics. In other words, if you can bring in some kind of a resolution or some kind of a policy level decision that before taking up a career in surgery, the student has to put in this many hours in a virtual environment or in the real environment on the cadaver in the anatomy department, then only I can come into the picture. Otherwise, I don't know how much I can help. But this is a decision you have to take within your surgical domain, and then I'm willing to do. In fact, I'm immediately after this thing, I am going to join an organization which is specialized in this virtual reality as in a full-time job. I'm ever willing to help, but you come to me with the proper level of implementation, which is beyond my capacity.
If I may interrupt, sir, how would it be possible to have some, I mean, I'm using the term very loosely, something like a fellowship, because people are all, once they finish MBBS or when they're doing some post-graduation, they go and get for whatever skills they need, they're going to certain places to learn. So like that, can it
Yes.
be like a primer? Like
Yes.
even if the Medical Council of India doesn't come up with a rule yet, would you be in a position to offer something like a primer course for
Yes.
surgeons too?
Yes, certainly. Or some kind of a credit point, this many hours you will have to clock on a simulator or something like that. Details we can work out, but it is possible and I'm willing.
That's an important point Vidya has brought in, because these days surgical trainees do go elsewhere to have an exposure to laparoscopy, robotic surgery, and all that. And because Learning Young Surgery is a platform from where we can start that, Dr. Balasubramanian has devised a course like this, and this is a structure, and then we can take it forward before the governmental agencies are, told about all these things. That would be a welcome thing. So because every surgical specialty, when they start off with their surgical training, their anatomic knowledge is, very basic, and it will help in a great way if they're exposed to some core anatomy to start with.
Can I just add one point to the learning? Am I audible?
Yes, sir.
Yeah. See, the competence-based learning is the in thing, which the Medical Council also insists on, and we have a detailed curriculum mapped out for both undergraduate and postgraduate. Now, the Medical Council doesn't really expand it into how you implement this kind of curriculum, but it is for the individual units and people like Balasubramanian. See, virtual reality and training is only one part of surgical learning. You need to map the curriculum to EPS, the entrustable professional activities and milestones recognized for a certain stage, for each stage of the course. And definitely the virtual reality and this kind of training will be a part of it and one of the EPS. But then it is a broader learning of the entire curriculum that has to be concentrated on, and that needs a structured program, which also includes this.
Okay.
Ilango, you're muted, you are unmute.
So thank you for being here. Thank you, Professor Balasubramanian. It has been a very engaging talk. You kept us
We want
informed.
more of you, sir, as frequently
Yes.
as possible.
Yeah, you
Sure,
kept
sir,
us
sure.
informed, educated, and it was an enlightening talk, 2 weeks for us. And thank you for all the participants to be here. We have been discussing for about an hour and a half. And like every good discussion, we have come up with more questions than answers. And I'm sure with much more interaction, we'll be able to go the extra mile in making a brighter future for our younger surgeons. Thank you. Thank you, everyone.
Thank you.
So next week we'll be making a 360-degree shift from anatomy straight into the operating room, and we will have Dr. Gijyadat Sharma talking about anger management in the OR. That will be next week's topic. And closing comments from you,
Bala
Dr.
is
Balasubramanian.
having something to say. Yeah.
Closing comments from you, sir, Dr. Bala.
Closing comments. I'm happy that although I very purposely cut short my talk exactly at 40 minutes, that is a self-imposed discipline. In no forum I have crossed the time allotted to me. I'm happy I was able to continue it in this forum also. I'm happy that beyond the 48 minutes, the amount of discussion generated is more important, because that is the essence of moving this forward. Uh, Now you deliberate amongst your faculty and specialty, and if there can be some kind of a synergy where we can move it forwards. Finding the funds is not an issue. But then we need a team to take it forward. As Dr. Shastri said, don't have to wait for the Medical Council of India to bring in policies or the university. Even a forum like this in association with, say, some college, let's say Ramchandra Medical College, Porur, doing a certification course or a 1 week training program or something like that. We'll have to make a beginning somewhere, evolve over a period of time to fit it into your overall requirement for training the medical student. And also, sir, Shastri sir, I just want to mention to you, the lab where I worked is about 1 kilometer from where you are working, NIMS. I worked with Dr. Neeraj in his lab, Medarsi EduTech, on Necklace Road. I
Yeah,
hope you know
Neeraj, I know
Dr.
very well. Oh, yes,
know.
of course. He's a close friend. I know him very well.
Yes, sir. I was there for 2 years. My institution gave me 2 years sabbatical leave, and I worked with him, sir. Nice.
My association with him dated back to Harvard Graphics 30 years back, when
Yes,
he used
sir.
to make PPTs with Harvard Graphics, and he had a slide maker.
Yes,
From that
yes,
time onwards, I knew him.
yes, sir. Yes, sir. Even now, I am in touch with him, sir. Although he has moved out of Medarsi, I'm still in touch with him. And he is working in this field, artificial intelligence, AR, and VR. He has started another lab. Thank you all. Thank you all.